let me kick off with the presentation, and I'm going to go through, and sorry, before I go, my declarations of interest. I'm a ESMO Scientific Committee member, but this isn't part of ESMO, and I'm a Sarcoma UK trustee. So, we all know about soft tissue sarcomas. The reason why I bring up this slide is just to highlight the different histological subtypes, and that's what creates the significant challenge in managing these patients. You know, how do we treat them all? We can't treat them all as one. And not only do you have hundreds of different subtypes, you also have tumors that arise in different parts of the body, and also young and old patients. So there's a lot to think about when treating these patients. So regarding the overview, what I will try and go through very quickly, and do feel free to interject, is to talk primarily about extremity sarcomas, and then move on to retroperitoneal and touch upon gynae, because I know there's sort of variation in the management. And then give you some recommendations regarding treatment of metastatic disease, and then specific considerations regarding pediatric cases. Now, just going back to that last case that was discussed, the tragic case of the alveolar soft part sarcoma, one thing I ask my radiation oncologist is, never be fearful, and also to all my colleagues saying, always think, is radiation an option in these cases? And if so, consider it. And with alveolar soft part, it's actually quite a radiosensitive tumor, so never stop treatment without thinking whether radiation can be offered. Do you want me to carry on with the mic? Okay. So, going through extremity and truncal tumors. So, where have we come from? We've got rare cancers, numerous histological subtypes, all anatomical sites. We have national guidelines, consensus statements, and how to try to unify practice in these patients. We have multi-center reviews, single institution series. As a radiation oncologist, we're always looking at pathological heterogeneity, the way they respond to treatment, timing of radiation, when can you offer pre-op, when can you offer post-op, when you're treating patients who are inoperable, can you deliver treatment radically to try to get really good control, or only low-dose treatment to offer symptomatic benefit? And when you do come to treating the patient, what do you treat? Do you treat the tumor and the region around it? What dose do you deliver? Always, you're thinking of the therapeutic index, the maximum dose to try and offer tumor control with low, but in the presence that you want to minimize morbidity. So, to my colleagues in radiation oncology, you learn the trade in all these different tumor subtypes, head and neck, breast, gynae, and you use those principles to treat patients with sarcoma. So, the most important thing about sarcomas, whatever we do, and one of my surgical colleagues uses this phrase commonly, tumor biology is key. The patient selection is the queen, and what we deliver in terms of technical maneuvers and therapies are the prince and princesses. We need to, as radiation oncologists, understand the surgical management of these patients so that we can work well together, and then how we can work together to improve treatment outcomes. So I go back to the O'Sullivan data. This is the landmark study, which looked at pre-op versus post-op radiation treatment in soft tissue sarcomas. Brian O'Sullivan performed this study in Canada, and overall, radiotherapy improved local control rates by 10 to 15% in most patients. 2-year local relapse-free survival was 90%. However, in the pre-op patients, you had increased pre-op wound complications in the pre-op cases, but this translated to a lower incidence of late effects for those who had pre-op, and this is quite important to know regarding morbidity. Looking at the wound complications, particularly, you're looking at secondary wound complications, wound breakdown. But if I could just focus you onto the cohort of patients where there was a significant dramatic difference, it's the distal lower leg where there were higher incidences of wound healing issues. And so this is really important to remember when you're trying to determine and selecting patients for radiation treatment. Looking at this data, the 5-year data has demonstrated that in the pre-op patients, you had a lower incidence of high-grade late toxicities, and this translated to a better functional outcome for pre-op patients. And again, I stress this is important to know regarding cancer survivorship. Further long-term follow-up data, and as demonstrated from that study, you can see that regarding joint function, grade 2 or less, was higher in the pre-op cases compared to the post-op cases, and also with edema as well. The Canadian group went on to do a phase 2 study looking at the original techniques, which were delivered with conventional techniques. And in these cases, with the pre-op patients, they were worried about wound complications, so they further analyzed and tried to minimize the dose to the surrounding normal tissue near where there's going to be an anticipated wound, so that if you can reduce the dose to those areas, you can reduce the toxicities. So this was a single-phase study, single-arm study of 70 patients, using a similar criteria to the original study. And what they noticed that the wound complication rate was lower in this cohort compared to the pre-op arm. Of course, you can't compare directly because they were two different studies, but it's interesting to see if you can reduce the dose to the wound sites, it can reduce wound complications. So consequently, in the North Atlantic side, they were offering pre-op RT as the standard of care. So how do we translate this into clinical practice? So this is a patient that my colleague was referring to us. So we see patients together with my surgical colleagues. And this patient is a lorry driver, 65 years old, who presented with this enlarged mass causing pain. And the quote from my colleague was like, I need to operate on this now, because if there's any further growth, this is going to render this patient inoperable. Obviously, the patient had a staging CT scan that was clear, but you could see this is quite an extensive tumor. So biopsy confirmed an undifferentiated pleomorphic sarcoma. What's going to be the radiological response, the pathology response? And so I can't predict that. None of us can predict that. We try to remember through experiences, but when we're not confident that these are not going to respond, it is best served for the patient to have the ultimate treatment of surgery and then consider post-operative radiotherapy, as this will, of course, offer increased toxicity, but you will give the patient the best chance of cure. So what do we look at regarding careful selection of patients for pre-op RT? Operability is key, and if they're borderline operable, radiotherapy does not, pre-op RT does not improve borderline operability cases. So you must be wary of that. The surgical colleague will always tell me what their predicted resection margin is to determine if they need radiation treatment. Will radiotherapy actually offer local control? Because many patients are treated with radiation and don't actually need it, but we can't determine which cohort they are. What is the predicted response to radiation? There are certain subtypes which do downsize with their treatments, and this makes my surgical colleagues very happy. Sometimes we make them so small that they get unhappy that they can't see the tumors, but we can't always win. Regarding those who do have post-operative radiotherapy, it's still a good treatment. It's a standard of care in many cases. So in those cases where it's patient is symptomatic, enlarged tumor, they're immobile, they can't get through a pre-op course, offer post-op RT. And of course, mindful regarding wound complications. Will my surgical colleague arrange patients to have surgery with a primary closure or a flap reconstruction, which is it in the distal lower limb or the proximal lower limb? All these things are taken into consideration. And what I just wanted to highlight is, on the left here, you can see local recurrence-free survival on a number of histological subtypes. Henry Smith was one of our surgical fellows who looked at our data set, and this is what's been published. And you can see that generally, with the majority of subtypes, the local control rates are very similar. Then you look at the distant metastases-free survival, and you could see quite obviously the pleomorphic sarcomas is a higher risk of metastatic disease in these patients, and therefore, within those first 12 months, if not up to 24 months, they're more likely to develop metastatic disease and local recurrence. So again, you're looking at the rationale for offering an adjuvant treatment in some of these patients. So in selecting the patients was key regarding histological subtype. This is a patient with a synovial sarcoma, 45-year-old lady, who's a policewoman, hockey player, presented with this lump. She received doxorubicin ifosfamide chemo, 3 cycles, and demonstrated a good response. And then we proceeded to pre-op RT, so a sequential treatment. And that's a pre- and post-treatment scan. And this allowed my surgical colleague to resect this lesion with a planned close margin, which still has been reported to show an excellent outcome compared to an unplanned margin. This is a case, and this is early on in my experience, where when we were starting off with pre-op RT, so when I first started, my surgical colleagues were very adamant, it was all post-op RT, and so we needed a lot of convincing. And we learnt together. This patient had a pleomorphic sarcoma. The lesion on the left is when he was presented. By the time he started treatment, that tumor was growing, and you can see even during his treatment, it carried on growing, and this was quite alarming. The patient, we persevered and carried on with the treatment, finished the radiation, don't stop. The patient had a very necrotic open wound. The patient was managed conservatively, resected with an open wound with a vac dressing to allow him to recover from his early toxicities before putting a reconstruction. And reassuringly, this patient has had good control over 8 years. Now, we were lucky here, but we learned from this experience that if a patient is having a tumor that's growing very quickly, proceed with surgery first and accept the long-term toxicities. So where are we at? In terms of techniques and treatment outlining, these are papers I've forwarded to you for your reference. There's consensus guidelines regarding how we treat these tumors in terms of the clinical target volume, what's the at-risk volume you need to treat. Astro guidance, so my colleagues in the US and Canada have put together Astro consensus guidelines as to levels of evidence to support pre-op, post-op RT. And of course, you've got your ESMO apps as well. So what next with regards to radiation treatment? We talked about pre-op versus post-op. We personalize according to subtype, patient, anatomical site, and size. Can we change the schedule or consider combination treatments or even change the dose? So I bring to you another case, a 76-year-old lady who has a myxofibrosarcoma on the distal lower leg. Now, commonly you want to be offering post-op RT because of the wound healing issues, but in terms of the location of the tumor, it's close to the knee joint. And in terms of looking at long-term function, this patient was not a smoker, no history of diabetes, so we were hoping that her recovery and wound healing would be a low risk. So she proceeded to pre-op RT. This patient had a lateralized tumor, high-grade lateralized tumor. We don't need to offer radiation pre-op in this setting because hopefully my surgical colleagues could consider resecting this with a good clear margin so we avoid radiation. But unfortunately, the tumor was growing by the time the patient had surgery and the deep margin was close. So a discussion was had with the patient regarding the risk-benefit, and the patient proceeded to post-op RT. And this treatment can be delivered very simply, lateralized treatment, avoiding treating the medial aspect of the thigh with little morbidity, and he carries on cycling. In terms of reporting these toxicities, so you've had to, NCI study reported the toxicities, but we've had many retrospective reviews and there's variations in the reporting of wound complications and toxicities. So we need a sort of consensus in how we do this. Rita Simoes is my PhD student who's looking at this and trying to define what are the toxicities and can we look into dose volume constraints, i.e. can we correlate the dose delivered to a certain region which could correlate to the toxicities patients experience to help advocate whether patient can have pre-op or post-op and report to the patient what they can receive and what toxicities they can experience. So conventionally on the left, you've got patients receiving conformal treatment. This is a sort of plan assessment. The actual clinical plan is the one on the right. But you see the target volume on the left, and then you see the region of red, which is 100%, 95% or above. And that's even outside the treatment, the volume. And so right on the groin, so you know this patient will have horrendous lymphodemas. But more importantly, you've spared the rectum and a lot of the normal tissue. But what about the IMRT plan where the tumor volume is treated more homogeneously and you've got low dose of the surrounding tissue? So which would be better? So you have to look at the risk-benefit regarding the areas that are treated, and with that, prefer the one on the right. The patient will have less lymphedema. The low dose of the rectum is not going to be a clinical issue. And so it's getting the balance right. So in the UK, you've had 2 clinical studies, Vortex, which is looking at post-operative radiation treatment, treating a large area versus a small area. This study concluded that the local control widths were similar and the toxicities were similar. IMRIS was looking at the role of IMRT in the similar limb cohort patients, pre-op, post-op, and what this study has concluded is with IMRT, you're getting a lower incidence of toxicities long-term, suggesting obviously that low-dose radiation is highly more conformal and reducing the dose of the surrounding tissue. So this is Rita, my PhD student, and she's been reviewing the data sets from these clinical studies, which is key because these are prospectively collected data with the matched radiotherapy plans so that we can then predict exactly what dose delivered where will, give us a guide of what the side effects are. So I move on to change of dose, and if a center is going to consider pre-op RT, the first cohort of patients to try it on are the myxoid liposarcomas. And you can see on the top two images, myxoid liposarcomas are exquisitely radiosensitive, and they respond really well to radiation treatment. And so we will routinely offer patients with myxoid liposarcomas preoperative radiotherapy. And I'll mention the study that was done we participated in. The image on the bottom there is pleomorphic liposarcoma, a completely different disease subtype, and this is generally radioresistant. So if we do see someone with a large tumor, we worry if this is going to grow through treatment, and the patient will have surgery first, followed by postoperative radiotherapy. So this is a 35-year-old lady who had myxoid liposarcoma. This is her imaging and her plan on the right. So I'm just going to show to you this patient who was participating in one of the clinical studies. So this gentleman, the 39-year-old, had this mass in the right upper thigh for 3 months. He'd undergone a biopsy, and this confirmed a myxoid liposarcoma, and you can see the imaging highlighting a 7 by 4 by 4 centimeter mass, no metastases. This patient participated in the study, the Do-Re-Mi study, which looked at the dose of 36 gray in 18 fractions, whereas the standard of care is 50 gray in 25 fractions. There's data to support that that may be adequate. And during the treatment, the patient underwent scans before treatment, fraction 8 of treatment, and fraction 16, and then 4 weeks after surgery, which is the standard time to scan. And so at fraction 8, you were seeing no changes in the size or no signal characteristic changes in the tumor. And the biopsy again confirmed the same. But what you start seeing at fraction 16, you're seeing early signs of response. You can see a size reduction, started to see size reduction, you see signal changes, and also in the pathology, you could actually start to see less viable cells, which is really encouraging. This is the patient scan at 2 weeks after they had a lot of MR scans in this study. But 2 weeks after radiotherapy and then 4 weeks after radiotherapy, you can see it's continued to respond. And remember, this is now measuring 5 by 2 by 1.5, and look what the pre-op size was. And this was the resection specimen after the surgery. So you can see in the pelvis, so it just hopefully correlates with the MR scan. The tumor was myxoid, there's a clear margin, and what was really important, the number of viable cells were less than 5%. So this is a very effective treatment as confirmed pathologically. The histological effect highlighted extensive fibrosis, hyalinization, and hemosiderin deposition. This is thanks to Kin Thwei, our pathologist, who explained this to me. So, cases where you do consider radiation as a pre-op setting or don't. And I've divided them into histological subtypes, anatomical sites, and other aspects. Looking at the histological subtypes, always really good to remember myxoid lipo, extrascleral, myxoid chondro, and I'll give you some examples of that. And also, I would add in alveolar soft part sarcomas. Obviously, if they have metastatic disease, you have systemic treatment, but you can use that alongside it. The truncal tumors, particularly the posterior rectus spinae tumors, where patients have had surgery with primary closure after pre-op RT, they have horrific wound healing issues. I'm sure Prakash may notice that and explain that. So unless the patient is going to have a flap reconstruction, you would offer that patient post-op RT. So knowing the surgical technique and the reconstruction is critical. And as I've highlighted before, patients with high risk of wound healing issues, rapidly growing symptomatic. There are a few patients who have paraneoplastic phenomena. They get anemic with the treatment, with the disease, and only recover following surgery. So these are the patients where you'd probably offer post-op RT. So again, this is a patient who had potentially had a marginal resection, pre-op versus post. The patient had pre-op RT. Why is pre-op RT preferred? As I've highlighted, lower total dose translates to a lower incidence of long-term complications, but in the lower limb, lower post-op complications may be higher, so one needs to be balancing the pros and cons here. And then your next thing is, we do deliver 5 weeks of treatment daily, Monday to Friday. Could you consider hypofractionation? There may be some challenges, and we'll touch upon the hyperfractionation in a moment. Also, you've got patient factors. Patients may be adverse to pre-op. They want the tumor out. They just want to get it out the way and not have to worry about it. They may be symptomatic. And they may decline pre-op or post-op radiotherapy because, like even here in the UK, we have challenges. Patients travel far and wide to have treatment in an expert center, and the financial burden falls on the patient also. So in terms of the radiotherapy pathway, I'll just briefly go through that. Joint clinical assessment with the surgeon is key. It helps with the relationship and getting a clear plan for the patient. Regarding the radiotherapy audit, you have, obviously, from a radiation oncology perspective, immobilization of each limb. You're always trying to spare normal tissue, so look into that, and you work really closely with your radiographers. And obviously, in terms of delineating the tumor, it's really useful to have an MR scan, if possible, IV contrast with the CT if possible, and try to fuse the MR and CT. It doesn't have to be an MR planning scan, but you could try your best to try and fuse those images to help delineate the tumor. This is a sort of reference of what we use regarding which sequences, and I may be corrected here, but it gives us some guide as to how to structure the tumor. So if there's edema, you want to encompass that in the clinical target volume. I've put in here brachy, and I don't have experience with brachytherapy. I know that Tata do. We don't use brachy, we don't have, and most guidelines now don't use that as a standard of care treatment, but in certain cases one must consider it. Our treatments are based on photon-based treatments for limbs and trunk. Some trunk ones may be beneficial for protons, and that goes via an NHS peer review panel. So many of our patients come from far and wide, and you can see in terms of these are the reference centers and how far patients travel. And so we have colleagues who do not treat sarcomas as their primary expert area. So we commonly do Teams meetings to share experiences, peer review volumes and plans. So we're always learning together. I work with a colleague, Shani Zaidi, and we work together and we peer review each other's volumes. I'd mentioned about hypofractionation, and there's a lot of discussion regarding hypofractionation at the moment. In the US, there have been a number of phase 2 single-center studies demonstrating local control rates that are comparable to conventional fractionation, but the wound complication rates are similar also, which is encouraging. But with hyperfractionation, there's a concern regarding late effects, and the data is immature. Immature. We're in discussions internationally in trying to develop a randomized study of conventional versus hyperfractionation studies and in limb sarcomas. Commonly, we're looking at 15 fractions, 3-week course. There are a few centers who have done 5 treatments, a week's course, but worried about horrendous toxicities from that. But the standard of care, and there's a consensus statement coming out that hyperfractionation isn't standard of care, and we should be considering conventional fractionation and hyperfractionation only in the context of a clinical trial. I mentioned about combination with systemic therapies. We've tried VEGF inhibitors. They haven't really improved outcomes in terms of efficacy. We have immunotherapy with radiation, and the SARC data is going to be presented by David Kirsch in ASCO this year. There's also trabectedin for myxoid liposarcomas combination working well with radiation. And in a metastatic setting, when patients are on trabectedin, we do offer radiation alongside in certain cases. Just going to give you a few clinical examples of pictures. So this is a 51-year-old gentleman with a fungating tumor. This was a myxoid liposarcoma. The standard of care should be amputation here. This patient was diabetic, anemic. The patient was absolutely against having an amputation. And therefore, we, with a heavy heart, tried to give him palliative radiation treatment, and we did. So yes, you could do radiotherapy, you could obviously offer surgery or chemotherapy, but more likely to consider a local treatment in this setting. This was his response to treatment, so he did respond well, but he was continuing to experience infection, skin breakdown, particularly being diabetic, and vascular path, and he finally resorted to a below-knee amputation, and sadly also consequently had lung metastases. This is another case of a foot. So this is a gentleman with an extraskeletal myxoid chondrosarcoma, and in this case, again, reluctant to consider an amputation, but we know extraskeletal myxoid chondrosarcomas respond well to radiation. So this gentleman had radiation treatment. He's now 2 years since his treatment, and he's responded and has good control, shrinkage of disease, walking well, slight swelling of the foot, but functionally doing well. So this is an encouraging outcome. Another case of an extraskeletal myxoid chondrosarcoma. This lady had 2 operations, had awful wound healing issues. She was a heavy smoker also. She represented with this tumor, as you can see on the left, inguinal nodes anteriorly, disease in the gluteal area going into the pelvis. My surgical colleagues saying, could you consider pre-op RT followed by surgery? And I'm thinking, yes, I can do pre-op RT, but I don't think it's fair to try and put this patient through surgery. So we committed to pre-op a primary RT alone. And a year and a half on, she's had good resolution, shrinkage down, and control of her disease. She's got no metastatic disease. And the tumor had broken down the skin, and this has all healed as well. So we're very lucky in this case. But just highlights the exquisite radiosensitivity of the tumor. So I'll now move on to resection margins. And some of these are presentations that I performed at ESMO, so there's a bit of duplication for some people. But a lot we need to know as radiation oncologists about WUP surgery and R1 resections, like what surgery has been, and so these are the list of things that I will just go through briefly. So we had a patient in 2009 presented with this nodule that had been excised under local anesthetic by a local dermatologist, and unfortunately this was a myxofibrosarcoma and referred to our institution. Patient had obviously had an incompletely excised lesion and had 2 centimeter re-excision of the margins, and unfortunately it did show residual myxofibrosarcoma extending onto the deep margin. So this is back in 2009, and the patient underwent surveillance. 3 years later, the patient re-presented with a possible recurrence at the top of the scar, and imaging confirmed this to be the case, as did the biopsies. And with this recurrent tumor, this was resected as much as possible with as big a margin and further cuff of tissue from the deep muscles. And so we felt that this was a low-grade tumor. We did not advise radiation because my surgical colleagues were confident with regards to the clearance. But because of the patient recurring, we needed to manage this patient, monitor them closely. And then, unfortunately, 12 months later, patient recurred. Resection was clear, but because of these multiple recurrences, patient proceeded to post-op radiotherapy. 9 years later, this patient has an infected seroma, and so the infected seroma was debrided. And what was noticed on that, and this patient had vac dressing, and I saw this patient 2 weeks ago, and there's a small area that's still healing, nearly 18 months on. And in this resection specimen, there were small areas of potential malignancy. So there's a risk, this is a high risk that patient's going to demonstrate fulminant recurrence. And this is the issue with myxofibrosarcoma patients. They have multiple recurrences, and the first operation is the most important. And those who have whoops resections, this is what happens. So my surgical colleagues always get upset, understandably, when these patients have inadvertent excisions. Was it planned? And then, obviously, we try to understand what does margins mean. And so we've tried to go through the literature and explain this. So you've got your conventional classifications describing R0, R1 being less than 1 millimeter. And I'm just going to skip through these, but this is all referenced in the presentation. But so we're talking about so as we talk about R0, 1 resection margins. And so our resection margins, I'll carry on chatting while you sort this out. So resection margins have been stratified, and the Toronto group have looked at their data in looking at R0 margins, a planned R1, an inadvertent R1, and an R2. And even with a planned R1 versus an inadvertent R1, you see that a planned R1, they have a better outcome compared to an inadvertent R1. So it's really important to ensure that you have a sarcoma surgeon offering the surgery and having a clear plan and understanding what's happening. And Prakash is nodding, so yeah, that's all right. So from the surgical perspective, we do that. So R1 margins can mean different things in different parts of the body. In the retroperitoneum, if they're close to the psoas muscle, but the surgeon's taken a deep fascia, we don't routinely rush in to say, oh, this patient needs radiotherapy, and I'll touch upon the retroperitoneal sarcomas. But in the limb, there is a need to offer radiation treatment, head and neck, critical sites. So you think of critical sites, you discuss with your surgical colleague, what are your concerns regarding margin status, and then we go from there. Okay, we're there. Right. We can carry on. Now it's not moving. That's allowed me to skip through a few slides. Okay. There you go. So yes, I was just mentioning about this lady I described. She had a planned R1 resection, good clearance. The risk of recurrence in this patient is quite low because the muscle was removed even though it was a close R1. It's the myxofibrosarcomas you worry about. So when do you deliver radiation treatment? In whoops excisions and re-excisions, you know that have a higher risk of recurrence, so therefore offer radiotherapy, particularly myxofibrosarcomas. Consider pre-op in those who are going to have primary closure. If you're considering a flap reconstruction, again, consider pre-op. Myxofibrosarcomas, now it's critical how you delineate these tumors. Yeah. So we always talk about this famous tail, so infiltrative pattern. Don't miss these as they're arrowed there. And so you have to be very generous with your clinical target volume in treating these. So with this patient who'd had these multiple recurrences, he received 66 gray. You delineated the original tumor and the current tumor, so you've treated the at-risk site as a whole. So radiotherapy is critical in inadvertent excisions. Take into account the clearance, the histological subtype, and closely liaise with your surgical colleague about what the concerns are. So in summary, I've talked about high-grade deep-seated tumors, pre-op RT, the dose, doing scans 4 weeks later, then aim for surgery 6 to 10 weeks after radiotherapy. Post-op, we've described histological subtypes that are sensitive to radiation treatment. Then we move on to retroperitoneal, and again, this will be a whistle-stop tour. So you've got a leiomyosarcoma, inoperable leiomyosarcoma. What's the evidence to support treatment? And these are the aspects we're going to look at, and it's a combination of clinical experience, real-world evidence, and expert evidence and clinical, so randomized phase 3 studies. The STRAS study, and I've provided this as a reference for yourselves, was a landmark study looking at the role of pre-op RT with surgery for retroperitoneal sarcomas. This study recruited internationally, and this was based on evidence to suggest that pre-op may have been of benefit in these patients. There was no difference in pre-op RT with surgery versus surgery alone. Radiotherapy was tolerated well. The interpretation is that radiotherapy should not be used as standard of care in a pre-op setting. But what happened is people did multivariate subgroup analysis and also looked at patients who were not recruited into STRAS. And what we saw was that in majority of patients who had well-differentiated or grade 2 dedifferentiated liposarcoma, they may have a benefit from radiation treatment compared to leiomyosarcomas and D-diff liposarcomas grade 3, as those patients have higher risk of metastatic disease. So this has been demonstrated in a combined analysis of the STRAS patients and the Strexit in those who weren't recruited into STRAS. So I've just gone through, experienced that. So, and then in pre-op RT, so what do we do in clinical practice? We routinely, internationally, we do not recommend post-op RT for retroperitoneal sarcomas. We don't see any benefit in that. When we take into consideration the clinical data for retroperitoneal sarcomas, consider it for grade 1, grade 2 D. diff lipos, personalized care when the surgeon's worried about an anticipated close margin, and then looking at the risk-benefit aspect. Patients who have recurrent retroperitoneal liposarcomas, there's a clear guidance as to consider radiation in selective cases, again, when there's a concern regarding marginal clearance. So this is a patient who had a nasty tumor on the right abdomen infiltrating the psoas muscle, and my surgical colleagues initially said this was inoperable. Patient received radiation treatment, and over time they responded well and continued to respond well 6 months on. And then after this time, there was increased activity on MR and there was growth. And then we went back to my surgical colleague, and the patient had surgery. And this patient had had a good effect of radiation, and what was really encouraging, this patient underwent surgery and is clear of disease. This is a patient who had surgery for retroperitoneal sarcoma, and they had a small area of recurrence near the kidney. And so what we offer this patient was stereotactic radiation treatment. So remember to use radiation where you can. Sometimes it's more effective than chemotherapy, and Jyoti and Andrea won't mind me saying that. With inoperable tumors, you can offer conventional techniques versus IMRT. You can offer protons, as you can see on the right. It's all about what do you need to treat, what dose do you need to deliver, and what are the side effects the patient's going to experience, and get the management from there, and work out the best technique you can offer. Radiotherapy can be used in combination with many of these patients with retroperitoneal sarcomas. Andrea will probably touch upon the role of immunotherapy and MDM2 inhibitors, and this is still work in progress. So in summary, for retroperitoneal sarcomas, there's no role for radiotherapy in the post-op setting, pre-op in selected cases, and radiotherapy offers good control for localized disease, inoperable disease. Gynae, again, there is a mixed picture here that many patients with gynae sarcomas are treated similarly to gynecological epithelial cancers. And this is a discussion I think we had at ESMO last year. And so commonly you consider it in the endometrial cancers, but in sarcomas, it's different. And so patients commonly, and so uterine leiomyosarcomas commonly present with uterine fibroids. They may have had morcellation, myomectomy causing peritoneal seeding. And in these patients, they have a high risk of metastatic disease rather than a true local recurrence. They commonly do not have lymph node involvement, so that doesn't really justify the use of external beam radiation treatment to the entire pelvis. And so with these patients, one needs to really look at patterns of recurrence, patterns of spread, to determine is radiotherapy useful. When you look at the evidence to support adjuvant radiation treatment, there isn't much there. There was the EURTC study and a few retrospective series and SEER database analysis. The EURTC study delivered 50.4 gray and 28 fractions in early stage tumors. There's no significant difference in local control. The risk of lymph node relapse was very small in LMS, and they're more likely to present with distant metastases, therefore didn't really demonstrate any survival benefit. The patients who did benefit were the carcinosarcomas, which are actually managed as a carcinoma, not as a sarcoma. And again, the Toronto group looked at similar outcomes as well. What I've also done here is given you a few examples to look at. So the evidence to support radiation, is there local relapse-free survival the same as cancer-specific survival? Can you use the analogy of other soft tissue sarcomas to use in the same setting in gynae sarcomas? For example, if they were to have a local relapse, pelvic sidewall, could that be feasible for surgery? If not, can you give radiation to that area? If it can give radiation to the area, it's not too morbid, then proceed with radiation to that area, not to the entire pelvis. Of course, the other concern is if these risk of metastasis is high, then radiation for local control is not really going to be of benefit. So a few examples of patients who've been on surveillance. They've had a vault recurrence and received SBRT for a vaginal vault recurrence, and this was treated with the MR-Linac. patients who've had radiation treatment with, again, SBRT. This is the same patient. And initially, there's concern that the patient's disease has grown immediately after radiation, but this is classified as pseudo-progression. And with sequential images, you can see that the patient has responded well. And then you've got patients who've had piecemeal resection, so high risk of metastatic disease. And then they've didn't have metastatic disease, but developed vaginal vault and recurrent obturator lymph node involvement. And they've received radiation treatment to that site with good control, but alas, thereafter have developed metastatic disease. And then patients who've had hysterectomy years ago for what was thought to be a benign fibroid, presented with a metastatic deposit, and this was actually a metastatic leiomyosarcoma, and have had stereotactic radiation treatment to the spinal met. Also consider reirradiation. If they've responded well before and there's good recovery, consider SBRT. That can offer good treatment control and response. And of course, think of palliation for single 8 gray for hemostasis. You know, this is commonly done, or high-dose palliative for consolidation effect, or radiotherapy for oligoprogressive disease. There's many ways to use radiation for sarcomas. So in conclusion, adjuvant radiation treatment is not useful for ULMS. There's not enough data to support its use, but consider it in selected cases. There are many confounding factors, particularly surgical procedure, and there is no consistent guidelines regarding gynae sarcomas in how you deliver radiation. It's a case-by-case scenario. And then finally, going on to metastatic disease. This is a patient, fit PE teacher, who had a tumor in the thigh, and on imaging has shown a cardiac met at the same time. So this patient underwent a cardiac MR to delineate the tumor in the interventricular septum and this large myxoid liposarcoma in the thigh. She proceeded with chemotherapy, had stable disease, no size reduction. So as she had no size reduction, she proceeded to radiation treatment, going back to radiotherapy being very effective in myxoid liposarcomas. We had no biopsy of the cardiac met, but we had to consensusly agree that this was a metastasis, and the patient was being planned for radiation treatment. And so we looked at what do we define the tumor itself, what margin. You add a small margin. You can't add big margins like you do with other sarcomas. And you look into motion of the heart, as you do for lung cancers, to determine how you manage and ensure that you don't miss treating the patient and what dose. This patient received 50 gray in 25. They tolerated it well, and they had a good response to treatment, stable appearances, and cardiac-wise, she was fine. And the reason why I bring this case along is you can treat the heart. It's okay to. They don't feel unwell with it. They don't get many toxicities, and it's a way of offering good control and good outcome for the patient. Sadly, the patient started to get progressive disease, oligoprogressive disease, and she started having whole body MR scans in these and multiple sites. She's had local therapies, and then sadly, she's now actually developed further recurrence over not the original site that's been irradiated. So this was irradiated, and then you've got new disease, superior and inferior. So the patient's receiving chemo, which we're going to see if we can actually offer radiation and minimize overlap with the previous treatment. If we don't, this patient will die. So you have that discussion with the patient as to what best to do. So that's the previous plan, and that's her current situation. And then a relapsed sarcoma, again, just giving you some radiotherapy principles. Patient had a thigh tumor, presented with intra-abdominal recurrence, as you can see in the back. Patient declined chemotherapy, was complaining of back pain. So declined all these systemic agents. Can we offer pre-op RT as the only site, but this was not operable. So the patient wished to receive palliative radiotherapy with good control. So delivered radiation treatment. So these are 3 different treatment plans, and you'll have these slides, and you can compare and contrast which you think will be the best. They're all deliverable, and it's determining what you feel the patient should experience in terms of toxicities. Do you want to avoid treating the kidney and not cause too much toxicity to the skin? And then finally, a solitary fibrous tumor, another disease where radiation helps. These tumors are highly vascular, and we commonly deliver pre-op RT to devascularize the tumors, and then they shrink down over time. This patient had a tumor in the pararectal area and declined in exenteration, so he received primary radiation treatment alone with good function. And 12 years on, he's been discharged with good function and no significant rectal toxicity. So we have all these different techniques. We can use IMRT, stereotactic radiation, proton therapy, treat the heart. You have all these resources in front of you, and you can select them to use them for all these patients and working together and try and come up with a plan. And then finally, specific considerations to be mindful of and why it's critical to have biopsies. Pediatric subtypes. We still get them in the adult patients. You've got Ewing sarcoma, and I think Jyoti is going to mention them later. Radiation is an effective treatment as an alternative or as pre-op treatment, and I've provided the Euro-Ewing's paper to highlight this. There's a new trial in development looking at radiation doses in these cases. And then rhabdomyosarcomas, and there's a FAR RMS protocol which gives you clear guidance as to how these patients should be treated regarding risk stratification, which chemotherapy combinations, when to deliver radiation. And again, radiation is very effective in these patients. So this is a patient with alveolar rhabdomyosarcoma of the paranasal sinuses who had complete response to treatment with chemo and radiation. So we have a wealth of evidence and information, but sarcomas are challenging to treat and in the UK, and so you need the expertise, you need peer review processes, but the patient burden is critical. How do you treat this cohort of patients in Bangladesh? I appreciate the rare cancers such as sarcoma in the context of the big cancer burden already. And it's all about what is the most important treatment. Patient compliance, is primary radiotherapy an option? Can we convince patients and teams to offer neoadjuvant strategies? Can you offer consolidation treatment or palliative treatments and stereotactic treatments? All of these are available to you. Never be afraid to ask. We don't stop asking. We don't stop learning in sarcoma. And we all work together to come up with a sensible plan for a patient. And we review each other's volumes. It's not criticism, it's learning. And through this and international collaboration, and with patients being involved, we can improve patients' outcomes. And so finally, I don't do this by myself. It's a number of members of our team who work together. This is all about everyone working together, and never be fearful. Thank you very much.